Okay, something's missing here. There's supposed to be the Durham Bulls image, but everyone's remembering it's this Friday at 6:35. You should have gotten an email notification about your tickets. You've got to show up there with a ticket, either a paper ticket or a ticket on your phone. Oh, there it is. It's one of those things you have to hit twice. Get out of here. Our all-star is Erin Balsis, nominated by Prachi. Erin goes above and beyond to make sure she does all the complicated epilepsy patients, and as well as a wonderful teacher to incoming technicians. Thank you, Erin. Coffee cups on your way. A couple things. Today is National Beach Day, but more appropriate for neurologists, it's National Bow Tie Day. It's the birthday of Mary Shelley. And if you don't know, invented Frankenstein. Betty White, is she still alive? Betty White, I think she died, didn't she? Yeah. And now Chris Hemsworth, who's now famous neurologically, he was Thor, but now he's the guy who's E4. It's also Ernest Rutherford's birthday, the father of physics. Laurie Sanders had a paper in Science with Mike Lutz and Rouge Pui, looking at a new blood-based assay for Parkinson's based on mitochondrial DNA damage. Deborah Koltai and Thomas Farrer looked at the effect of various anesthetics on cognitive function in applied neuropsychology. What does Jonathan Morena love about neurology? It's that it's a puzzle, every patient's different, and it prevents monotony. Good for him. The Triangle Heart Walk is October 8th. Just email Will or Wayne if you're interested in walking. Thanks to everyone in the department who took part in the 10th anniversary of the department's Boost plan, which is for Durham middle school students to teach them about neuroscience. And there's Len White and residents and other faculty. So thanks for everyone who's doing this. This again is today's CME code. And today's case is going to be done by Felix. Felix, you want to come and take it away? That's what I'm going to do when I'm retired. I'm going to be AV tech, roving AV tech. Come on in. Okay, do you share screen?
Let's see.
See? So take that one. Yep. Yep, go forward and hide your meeting controls. Just this thing. Meeting controls.
Okay. Okay, so I'm Felix, one of the third-year neurology residents. I'll be talking about an interesting case that we saw in the consult service, which involves that of a 79-year-old gentleman with a history of prostate cancer, treated with radiation, also history of alcohol use. He came in with symptoms that began as nighttime numbness and tingling in both feet with crawling sensation. And this began about 6 months before he presented. He then had symptoms that evolved to infrequent jerking of the left shoulder, occasional twitching of the mouth, and wiggling movements in both arms and legs that worsened with stress, improved with sleep. He had worsened dexterity, couldn't hold objects, couldn't really drive. His speech became forceful, strained, and quieter. And he started complaining of chronic constipation. He had dry mouth. He had difficulty sleeping, woke up frequently at night, and was gasping for air during the day, which then progressed at night, which then progressed to the day. And he also endorsed some anxiety and worsening depression. On his examination for cognitive, he scored a 21 out of 30. He had slow saccades. He had increased muscle tone with tremors, peripheral movements, and what's called the milkmaid sign, decreased temperature and absent vibratory sensation in his lower extremities, and his gait was wide with a steppage pattern. So we went straight for investigation. He was concerned about Huntington's disease, which came back negative. And then we sent an encephalopathy panel, which showed in serum high Eglon 5 titer IFA, which helped us clinch the diagnosis, and he was sent into the inpatient service for treatment. So he underwent 5 days of Plex, 4 days of IVIG, and then he was discharged. His exam was relatively unchanged at that time, with a plan for rituximab in the outpatient setting. So what is eglin-5? Eglin-5 is one of a family of 5 genes which are listed. It is predominantly expressed in the brain and retina, and the function is not clearly known. It's thought to be involved in neuronal adhesion, neurogenesis, and plasticity. And the regulation, as you can see here, so it's thought to be anchored by a GPI anchor to the cell membrane, doesn't have a transmembrane domain. And so you have metalloproteinase enzymes, matrix metalloproteinase that cleaves the GPI anchor, makes it the ectodomain sheds into the CSF or serum, where it can actually form homodimers or heterodimers, and the function of those complexes are not clear. And because it doesn't have a transmembrane domain, it's unclear how it actually performs its signal transduction. So the possible mechanism here is that the molecular structure of this protein can induce antibody production. It's thought that in patients who have specific HLAs, some specific type of tumors or viral infection, you can have induction of B cell proliferation to plasma cells and antibody production. And this antibody can stay in CSF or serum. So the antibody is thought to bind eglin-5, prevents its interaction with neurons, and that's the IgG4. The IgG1 antibody is thought to result in irreversible cross-linking and internalization of the eglin-5 into the cells. So again, preventing the interaction with neurons, and that could result in cytoskeletal disruption and synaptic destruction. This is all in vitro. And so there's another pathway that suggests that you can have glial activation resulting in inflammation, and a known pathway which could directly result in a neurodegeneration kind of presentation with the accumulation of p-tau in different parts of the brain, including the hypothalamus and the tegmentum. So there's a lot of questions to be answered there. The first patients were discovered by a Spanish group in 2014. There were about 6 patients presenting with sleep symptoms and movement disorders. The incidence, it's thought to be rare. About 100 cases have been identified, at least back in 2019. The onset is about 45 to 70, and there's males and females are affected equally. So the diagnosis of anti-eglin-5 disease depends on looking for the antibodies in CSF and serum. Thought to be 95% in serum, 100% in CSF. In one study, it was 100% in serum, and those 2 extra patients had a PSP-like presentation. There's a strong link with HLAs, especially the DRB1 10.01 and DQB1, which is in 86.6% of patients in one case series. And when you look at the HLAs, the risk ratio seems to be, for this HLA seems to be higher than the general population. And so it's something to be tested for. And when you do postmortem staining, there's the p-tau accumulation again in the hypothalamus and in other regions, including the periaqueductal system. And you can do some other testing which are non-specific for sleep, brain imaging. So for the treatment, we have monotherapy, which I've listed here, or in this table, including IV corticosteroids, IVIG, Plex, and rituximab, but it's thought that a combination therapy is much better. In this case, one study recommended combining IVIG, Plex, and rituximab with a response rate to monotherapy at 31.8%, 66.6% for combination therapy. So if you imagine that the IVIG or the Plex binds to the antibody, then it prevents the pattern where eglin-5 is not able to interact with neurons. So if that is identified early and treatment is instituted early, then one can prevent accumulation, at least the prevent this dissociation between eglin-5 and the neurons, and prevent p-tau accumulation downstream. The mortality rate is still pretty high. This is with paper in 2017 showing up to 59% mortality rates, and in another paper it showed 34% in a series of 58 due to central hypoventilation, aspiration, and cardiac problems like Takotsubo's. So the takeaway is identify early, screen early for patients presenting with unexplained sleep disorders, bulbar dysfunction, gait difficulties, oculomotor abnormalities, chorea, and cognitive deterioration. And there is a ton of research that needs to be done to better identify the pathophysiology of this disease. Thank you.
Thank you, Felix. Chris, you and I shared don't we have an Iglon man that I thought had Alzheimer's and I sent him to you? He had a positive antibody. Remember, and you tried to talk him out of it, and it worked because the next time I did the assay, it came back negative. Does it have a false positive? It does, yeah. So maybe that's what happened to this guy, or maybe you just like talk therapy worked. All right, so thank you, Felix. It's, obviously my pleasure to introduce Chris. Chris came here probably a year into my tenure, so that's about 8 or 9 years ago. I made a call to Justin MacArthur at Hopkins, and I said, Justin, I got a great MS team here, but I really need somebody else too. And he said, well, I know this guy, Chris, who had been his fellow up there. Chris and I we might have overlapped, but I don't remember Chris from that. But I mean, that's the single best recruit that I've made since I've been down here. Chris has just been a huge force in the department, both in his role in the residency director and his role running the MS program, and in his role as just being a phenomenal doctor. I mean, I'm an old man now, and I've been around some phenomenal doctors in my career, and I wouldn't put any of them ahead of Chris in that regard. So, I know that's a real compliment for me. I used to think I was a good doctor, but now I know I'm not. One day in resident clinic convinced me of that. So just by way of background, Chris where'd you go to college, Chris? It's not written here. Okay, so Chris was like a UAB lifer for quite some time until he broke out and went to Hopkins for a fellowship, and then back to Alabama, where he rescued us by coming up here. And I'm thrilled to have him give a talk today. The title of his talk is Autoimmune Encephalitis, an Update. And just by way of background, since I am old, when I was a resident, we had patients who came in and died, kind of semi-acutely. We didn't know what the heck was going on, but we used to call it, what do we call it those days?
Steroid response.
Or Hashimoto's, right? And we would just sort of throw steroids at them, and nothing would work. It was really a nightmare. And then, was it the fellow at Penn was the first one? Dalmo was the first one to describe, and then suddenly, whoa, that's what it was? Yeah.
That's right.
That's a little historical perspective. But just try to imagine what diseases that you folks are seeing now that when you're older, you'll say, God, I didn't know that's what it was. How did we not know that? A career is a long thing. And this stuff didn't even exist when I started. There was no treatments for MS, So for folks in the neuroimmunology world, things have changed pretty dramatically.
Yep. I think, yes, we are very busy. And I think over the last 10 years or so, it's been a really exciting time in neuroimmunology. So thank you, Rich, for the introduction. Thanks, Felix, for a great case that I think ties into some degree to what we're going to discuss today. And so I altered things just a little bit. We're going to talk about autoimmune encephalitis and specifically kind of focus on misdiagnosis and hopefully how to avoid misdiagnosis. This topic came up for a couple of reasons, one of which is in our clinic here, we see a large number of people that come through that have carried this diagnosis, as well as kind of a secondary reason that some of the other faculty, specifically some of the ICU faculty, have asked about some guidelines on maybe when to check for autoimmune encephalitis. So I have some numbers in here that we'll talk about. We check a large number of these panels. They are very expensive and they are pretty significant cost item for the hospital and for the lab specifically. So I don't have any disclosures. So hopefully what we'll hear today a little bit is just some, common pitfalls that can affect misdiagnosis and lead to this. And then really kind of when and what should we be working up and ordering in a lot of these folks. So these are not numbers from our clinic. Someone else has looked, a few other sites have looked at this. So with one of the largest studies I was able to find with multiple tertiary referral centers that really focus on autoimmune encephalitis, they looked at all their referrals and all the people that came in, and then they evaluated them to confirm the diagnosis. And about a quarter of those patients that had been previously diagnosed didn't actually have or meet any criteria for autoimmune encephalitis. Most of them had other diagnoses that were identified. So we'll see the possible AE criteria here in a second. 3/4 of those patients didn't even come close to qualifying for that. You can see some of the breakdown here of other disorders that came in and what their actual diagnoses tended to be. Obviously a very common one, and I think anyone who works in our clinic can attest to this. We see a lot of functional neurologic disorders, a lot of primary psychiatric disorders that come through carrying a diagnosis for a variety of reasons. We've had a few dementia folks come through as well. And then a surprising number of people come through that are on, let's just say, a lot of medications that can impair cognitive function. And sometimes it's as simple as whittling down the medication list in order to get them a little more awake, a little more alert, a little more clear-headed. So without knowing specific numbers in our referrals, I actually think our numbers are probably higher than this as far as misdiagnoses. They're significant enough that now this is the only diagnosis in our clinic that I screen every referral for and turn the vast majority of them away.
Is that people with an antibody?
No, these are people who are not seropositive. These are specifically people who come in with a diagnosis that has not been confirmed by an antibody. So there are seronegative autoimmune encephalitis cases, but you have to be very cautious about this. And this is one of the key points I hope people take away is seronegative encephalitis is not a diagnosis that should really be made lightly. We definitely have cases. We definitely see them. They come through. There's rationale for it. And there's actually well-established criteria for that diagnosis. And we'll go over those in a few minutes. But so I think one of the big questions is, why do we run across these misdiagnoses? Why do patients get labeled with this? And I think there's a variety of reasons. And when other sites have looked, they came up with a few criteria, which I'll list out here in a second. But I actually think we can sum up a lot of them in a few phrases. But so, as I've alluded, these are really common in clinic. Mimics are actually far more common than encephalitis. And there are risks associated with misdiagnosis, specifically if you think about unnecessary immunosuppression. Patients, especially if they're misdiagnosed, sometimes get called refractory. They get put on more intense and more potent and more broad spectrum immunosuppression over time, which have more and more complications. And then there's obviously the delay of, whatever their other underlying diagnosis may be. And so, as far as reasons for misdiagnosis, I think you can get trapped. I think it's easy to hang your hat on one feature and say, hey, this looks a lot like, a limbic encephalitis. This looks a lot like an autoimmune encephalitis without putting anything in the broader clinical context. So it's really easy to look at one thing and start to think about this diagnosis. And I think it's been kind of the fad diagnosis for the last few years. We're seeing more and more of this. Publications have gone through the roof on the topic of autoimmune encephalitis. And if you see this MRI without any context, it's really easy to look at it and say, hey, what's going on here? This looks like somebody who could have an encephalitis. Now, it could be infectious, right? Could be inflammatory, but the story makes a big difference. So this is a 40-year-old woman who had a year-long process of gradual cognitive impairment with a pretty profound anterograde amnesia. And the entire time I met her, I don't think she ever remembered my name. Spinal fluid normal. The only abnormality we really ever found was she had this MRI. And if you tracked it over time, it got quite a bit worse. And this is actually gliomatosis cerebri. And this is probably the 4th case that I've seen that looked just like this and started just like this. All right, so I think you have to be a little bit cautious about having a story that doesn't fit and then kind of hanging your hat on a blood test or an image that maybe pushes you in that direction without the other features that can go along with it. So, you know, the big pitfalls are going to be, again, over-interpretation of some single aspect of the case. And so over-interpretation of a serum antibody, over-reliance on serum testing alone, which we'll get into. This could be a, you know, back and forth. There's a lot of debate about this aspect of autoimmune encephalitis diagnosis at the moment. But I think misinterpretation of non-specific or functional symptoms. This is an incredibly common reason that we see people in clinic. They come in, they say, hey, I've had this brain fog, this cognitive issue going on for a long time. Someone checked some blood work. They said I had a little bit of inflammation in my system, and now they're chasing this autoimmune encephalitis diagnosis. Imaging felt to be consistent, much as we've seen. And then, admittedly, there is both on the patient and the provider side, sometimes reluctance to accept another diagnosis. I've had a number of providers call me and demand that I work up this patient and treat patients for autoimmune encephalitis when it seems very clear that that's not the case. So to kind of go back to some of the antibodies, there are some more common culprits within this realm. And some of you will not be surprised probably to see, others might be a little surprising. This one probably doesn't shock anyone in the room, hopefully. So thyroperoxidase is one that gets checked very frequently, commonly associated with this Hashimoto's encephalitis picture, of which most of the people that write about Hashimoto's can't even agree whether or not it exists. So, you know, in the setting of people with thyroid disease, you're going to see thyroperoxidase antibodies, and I think you have to be very cautious. So when Dalmau and his colleagues outlined the criteria for autoimmune encephalitis or proposed these criteria, they actually did put a category in for Hashimoto's. And if you look at it, it's incredibly vague. You know, it's a really difficult one to pin down. And a lot of kind of experts in the field are not totally convinced that this is really a significant marker or that Hashimoto's is a true presence. Another one that hopefully most of the residents, at least in the room, are not surprised to see on the list. So GAD65, and I have a couple tables in here somewhere that talk about our levels. So low levels are very common, both in the general population and incredibly common in type 1 diabetics. So here's where titers matter. And this one also gets a little challenging when you start talking about serum versus CSF. Voltage-gated potassium channels. Been around for a long time. This is one of the earliest antibodies that was discussed and published and really commercially available. I remember this coming out when I was a resident, and everybody started getting potassium channel antibodies checked. There were all these papers that came out, and one in particular that scared everyone in my residency a few years ago was this list of all these syndromes associated with potassium channel antibodies. And it was everything from neuromuscular disease to CJD and another 2 to 3 dozen diagnoses that were listed as testing positive for potassium channel antibodies. We saw a number of people come through when I was a resident in Birmingham, lots of CJD, lots of these kind of unusual diagnoses. We checked everyone after that because we were terrified that we were missing treatable disorders. Not a single person ever came back positive. And fast forward now to present day, and this antibody is actually being taken out of a lot of the panels because by itself, it's just not specific enough to actually make a diagnosis. You see a lot of very low level titers, and a voltage-gated potassium channel in the absence of LGI1 or Casper2 may not be significant at all, right? So a lot of the paraneoplastic panels now are starting to take this one out and really focus more on the specific LGI and Casper2 antibodies, which are actually bind to some other proteins that then interact with the channel itself. So voltage-gated potassium channel, by itself, probably not something that we should pay as much attention to. And this might be the one that surprises people, NMDA. right? So we tend to think of NMDA as incredibly accurate, highly specific antibody. You find it, you should be concerned. And I would say if you find it in the appropriate person that you had a high suspicion and were checking it in, yes, you should be concerned. And while it is a highly specific antibody, there are false positives, right? So this is one of the ones that very clearly is more sensitive in the CSF, while reasonably sensitive in the serum. It's definitely higher in the CSF. Specificity is fairly high, but you can see false positives in a variety of disorders. And there's several cases of HIV encephalopathy that have been reported to have NMDA test positive. This is a patient from our clinic who I have now seen for approximately 3 to 4 years. Again, she's now 42. She came in with a little bit more of a insidious progressive cognitive presentation, never seized, never had dysautonomia. And the question became, did she have MS, which is what her diagnosis through the door was, at least. I'm not sure that's accurate either, considering the one on the left that you're looking at is a T2 flare. The one on the right is her gadolinium enhanced T1. It's looked the same for the last 3 to 4 years with the contrast enhancement despite treatment. At some point along the way, someone, not me, because it wasn't high on my list of suspicion, checked an NMDA antibody, both in the serum and CSF, which came back positive. She has never behaved like an MDA. She has not responded to treatments like an MDA. And she literally walks through the clinic door, looks perfectly normal, aside from being a little bit forgetful with some mild executive dysfunction. She has a job, she holds it down, she manages her house. She shows up every 6 months. And every time she shows up, I'm kind of surprised to still see that she's alive because I have no idea what's going on. This has been biopsied, but you can't convince me that it's an NMDA encephalitis. All right, but she continues to test positive in the CSF. And then a few of these I think we've seen. These are some other antibodies that are commonly now disappearing from paraneoplastic, specifically panels. So the ganglionic acetylcholine receptor antibody, I think, has driven many of us crazy because we never know what to do with it. Striational kind of falls into the same boat there. And then the N-type calcium, I believe, is disappearing from the Mayo panel here shortly as well. Amphophyssin, Casper2, and a few others certainly are significant. They will still be around, but you really need to be very careful about interpreting them in the serum without any other findings and without CSF to go along with it. Their clinical syndromes tend to be a little more specific and a little more targeted. So how do you then prevent it? Well, much like I just alluded to, know the clinical scenarios where you should really be thinking about these. I don't think we should be sending this in these panels in a kind of shotgun approach. There's probably very little reason for residents to ever send an autoimmune encephalitis panel in the middle of the night. It takes 2 weeks to come back. There are clinical presentations that go along with it. You can wait a few hours. It can be discussed on rounds, and then you can decide if it's worth it. A serum autoimmune encephalitis panel to Mayo, by the way, costs $1,400. All right, so think about how many of those we send. So this is the diagnostic criteria for possible autoimmune encephalitis, okay? So this is not seropositive, folks. This is the general, kind of first pass. When should you think about even checking the antibody? So this was proposed by Daumau and Grouse in 2016. These have been validated. The specificity and sensitivity of these criteria is actually really good, even in some follow-up analysis from about 1.5 years ago. And so they're actually fairly straightforward. So, when you start to see criteria and look at these tables, sometimes it can be really overwhelming, I think, at times. This one, I think, can be summarized almost in one line. If you kind of think about the MS criteria that's pages and pages long, we often summarize it as dissemination in space and time. This diagnostic criteria, I think we can say subacute behavioral or cognitive change with something else. All right. So criteria 1 kind of gets at the subacute, meaning roughly, 3 months or less fairly rapid onset memory or cognitive changes. The altered mental status here with the asterisks implies alertness, consciousness, and then subacute onset psychiatric symptoms, which does make things a little more complicated, admittedly. That's has to be present. All right. Step 2 is the one that I think sometimes gets ignored. All right. Spinal fluid, focal findings, seizures, MRI features. You need something else in my mind in order to really have a high suspicion for autoimmune encephalitis. And so I think number 2 is the one that frequently gets ignored, especially in non-neurology services. All right. Number 3, which, yeah, you can't see on your screen either in the room, basically says rule out other diagnoses, which I think sounds straightforward, but again, often gets ignored. There are some other clinical clues, even for more specific antibodies. Some of these antibodies you can check specifically if you're concerned about them. I don't actually recommend doing that very often because there is a lot of overlap in a lot of these antibody syndromes. But there are a few clinical clues. I think we've had many of these come through our services. Older patient who is acutely or subacutely confused, and you're having a lot of difficulty controlling the sodiums. I think we had this a couple of years ago where we had a woman on service that we just could not get her sodiums up, and she was just a little, off, and she ended up having LGI1. I think just from our clinic, I can tell you our volume of antibody positive patients in our clinic here at Duke, probably the most prevalent one is going to be LGI1 that we find. NMDA, while being the most common antibody associated with encephalitis, is more common in people 30 or less, 30 or younger. All right. Older patients tend to have these LGI1 and some other antibodies that we see. So I think we get a little bit of a referral bias there. Facial brachiodystonic episodes or events, I avoid the term seizure because they don't tend to have epileptic EEG correlate. And I didn't want to offend any of the epileptologists who might be listening. So facial brachiodystonic events, these are very characteristic of LGI1. There's great YouTube videos that you can look at. Many of us, I think, in the room have seen these. They're very brief. It's a very quick spasm of the face and arm, typically to one side, and it can alternate sides, and they occur sometimes 100 times a day. They do not have alteration of awareness. They are very steroid responsive. If you see these, you send it off and you start treating. All right, it's practically pathognomonic. Stiff person, these are less common to see than the cerebellar ataxia from GAD. However, if you do see someone who has a classic stiff person presentation, GAD 65, you are generally going to find in very high concentrations. Glycine I put in here, even though I think we more associate it with PERM, progressive encephalomyelitis with rigidity and myoclonus. But you can see it as well in a stiff person presentation, and they tend to present very similarly in the beginning. To allude to Felix's case here, the one that doesn't necessarily obey the rules very well would be Iglon 5. It tends to have a much more subacute to chronic course than the classic autoimmune encephalitis, but their course in general is a little different. They often have atypical Parkinsonism. They have sleep disorders. The paper who described this described 5 distinct phenotypes that are actually pretty good. And so this is the one that you have to be a little bit cautious about, I think, and think about when you have a more rapid onset Parkinsonism than you expect, even if it is a little slower than the classic autoimmune encephalitis. They don't tend to be quite as acutely altered as our typical patients do as well. No, absolutely not. It is incredibly rare. And it doesn't respond very well to treatment based on longer term. So this kind of becomes a discussion about if you checked it and found it, what would you do? So you'd immunosuppress a bunch of older patients. And then I would say, we can try a couple of things. It's probably not going to work. And then we may, and then we'll go forward. So I don't think everybody should have it checked by any means. It just doesn't make sense. It's too rare. Again, one of the reasons I kind of got into this topic was after some discussions with the ICU. And so, the ICU obviously sends a fairly large number of these panels, both in the serum and CSF. And they've gotten a little pushback, I think, from the hospital lab because of the expense and because of their yield. And so looking at this specifically, is there some guidance that we can give? Is there some different criteria that should be applied? I think the answer to that latter question is no. I think the same basic criteria apply. However, there is a tool that can be used to guide not just the ICU, but pretty much everyone in whether or not they want to send these antibodies. And so this antibody prevalence and encephalopathy score, this was actually developed about 5 years ago. It's APE2 score is the short for it. There's actually a calculator linked through Mayo. It's incredibly sensitive and actually very reasonably specific if the score is greater than or equal to 4. Subsequent follow-up analysis of this in different cohorts in different populations continue to confirm that the sensitivity is greater than 90% in almost everyone that's been looked at. The specificity varies a little, but I think the key here is trying to find the patients that we actually want to send the antibodies in. So I think the sensitivity is probably the more important here. This is a breakdown of what it looks like. And if you go through, it really hits a lot of those possible AE criteria and a couple other things. If you go to the Mayo link that's on there, it's got little boxes next to each one of these. And just in case you can't add 1, 2s, and 3s up to 4 or more, it will do it for you. However, this is a really quick reference that you can look at, and very straightforward, very easy, and incredibly accurate given the data that we have. And so I think for those of you rotating through the ICU, or if you're trying to figure out, should we send an antibody panel both in the serum and CSF, this would be a really nice tool and would probably cut down on a lot of the, excessive AE panels that are going out. So this is the one that gets a little trickier, I think, right? So I alluded to this a few minutes ago in that you want to be very cautious about relying on certain serum antibodies and probably cautious about relying on just serum. And so if you see this line I put, if you can only pick one, pick the CSF, maybe. So this is actually a pretty hot area of debate within the encephalitis world at the moment. There are some large centers who do a lot of antibody discovery who would say this is not the case. There's at least one center that does antibody discovery that says this is definitely the case. So I think it's a little bit more nuanced and a little bit more challenging to answer. In most patients where you have a high suspicion, if you ask even people at those centers, because they did this, they send both. They send the serum and the CSF in patients that they have a high suspicion for. I think that's reasonable. Where this kind of, if you can only pick one, pick the CSF came from, is actually Dalmau himself is the one who pushes this. For a long time, I think we have kind of had this idea floating around that things in the CSF that are more sensitive include NMDA. I think that's very clear. GFAP also more sensitive in the spinal fluid. It's been well established. In the serum, we've often not, I think by saying that those are more sensitive in the serum, I think we've implied that more sensitive in the CSF. We've implied that the others are more sensitive in the serum. I think they're reasonably sensitive in the serum. I think it's hard to say that they're more sensitive in the serum. LGI and Casper has been thrown around quite a bit as to that are more sensitive in the serum. Everything else is kind of a wash, all right? Where this comes from is Dalmau's group thinks that the LGI and Casper being more sensitive in the serum is actually being overemphasized and may not be accurate, quote, if you do the test the right way. To my knowledge, no one is doing it the way that he thinks it should be done. And even Santosh Irani, who actually holds the patent for LGI and Casper, says they're more sensitive in the serum. So he's out of the UK, although I think he's moving to Jacksonville in the next few months. So as recently as this past year, the Mayo group did publish a big article talking about each and every available antibody in the Journal for Applied Laboratory Medicine. Yes, I did pull it and read it. And went over which one's more sensitive, which source, which specimen is preferred. They, out of the 2 to 3 dozen antibodies that they looked at, they only made a determination on about 5 of them, and they're the ones that we've just commented on. Everything else was, who knows? All right. GAD, I think in this case, is a really complicated one because while GAD can be found in the serum and CSF, the levels that are significant in the CSF have never been well established. The consensus on that is unclear, whereas I think we know much more about serum levels and their importance than we do the actual CSF levels. The other part of that is with GAD, it seems like if the serum concentration is high enough, that is actually the threshold that determines whether you find it in the CSF. So most of the time, I think it's a relatively safe bet to say that if it is clinically significant from a neurology standpoint, you are going to find it in the CSF. The level may not be as relevant. So this is our GAD data. Now, these tables, forgive me, this is all from Slicer Dicer, and I think I have some concerns about the accuracy of some of the Slicer Dicer data and how accurate and how inclusive it is. But I think this gives a pretty good, at least, idea of what some of our levels, and this is serum GAD specifically, by year over the last 5 years with a year to date at the end. You can see we're checking more and more of them. This includes GAD that was sent by itself, as well as GAD as a component of the autoimmune encephalitis panel. So if GAD was sent as any part of any of these tests, it's included here. And so you can see we're sending a very large number. It seems to get higher and higher with each year. The year to date, we are on track to surpass last year. The pink, magenta, whatever color that is, column is the normals. All right. The blue one on the far left is the abnormal GAD with a concentrate with a level less than 5. All right. The shorter blue column in the middle are the abnormals that have a concentration above 50. All right. So you can see that even within our data, roughly 20% or so of patients are coming back with positive serum GAD levels that are likely not clinically significant. I would say also, if you add all these numbers up, you know, looking at about 1,100 and we've got a hit rate of about 18 significant, I think we should probably be a little more judicious in our use of some of these tests. So I did not pull the CSF data, but I thought this was just a good indicator of kind of the percentages. And this 20% or so of people having a positive GAD does hold with what's previously been published, right? So a lot of people with type 1, specifically diabetes, will test low positive GAD, but a pretty significant portion of the otherwise healthy population also tests positive for low level GAD antibodies, right? We get loads of referrals for this 0.15 GAD antibody level in someone who is perfectly normal. And I usually can't figure out why it was checked. And so the other thing, and I think this will be hopefully a little bit of an education point for many people in the room, is check the right panel. So over the last several years, I think we've all seen additional antibodies come through. More and more of these panels have popped up. And so we tend to get in the habit of sending what's quick and easy and what we know. But I do think we can get more targeted and more specific information based on the specific panels that we choose. Now, this is not the right answer. It's not to send the autoimmune encephalitis panel as well as a whole bunch of other ones. There's loads of overlap in all of these panels. So in our Duke data, in the CSF, up to 10% of patients are having both a paraneoplastic CSF panel and an autoimmune CSF panel sent at the same time. All right. There's no use for that whatsoever. You know, about half the panel is the same. I don't know. I got to investigate a little more if this is because of an order set that has them both on there and people just click through. I can't tell you that this is all coming from our service or not, because there are other services that order these. But the reality is people are not ordering the right things, and they're overlapping the same tests numerous times. It's the same thing as ordering a GAD, an LGI1, and an autoimmune encephalitis panel. Why are we doing this? Or sending an MDA and an encephalitis panel? They're included, right? We should just pick the one. So I'll show them in a second, and I think it really does determine what you're looking for. So the one that you use in clinic, I would suggest should be different than the one that on average I'm going to send. So it's up to about 5% in the serum that gets overlapped. And so this is probably the big takeaway. The paraneoplastic panel is kind of deprecated. It's outdated. We really should not be using the paraneoplastic panel, the one that goes by that title. All right. Both Mayo and the Utah lab, ARUP, have really changed their panels to target syndromes and specific specialties. So this is, again, our encephalopathy and paraneoplastic panels in the serum by year. These are, again, overlapping. You can see the numbers we're talking about here. This is the CSF, and so we're still seeing a lot of both of these panels be sent. Our NMDA in the CSF, you can see, aside from 2020 COVID year, we're sending a large number of these, and we've got about a 1% hit rate. All right, so this is actually a big deal for the lab. And there are many hospitals around the country that have put pretty strict criteria on when you can order an autoimmune encephalitis panel of any sort. And so I think one of the goals of doing this today is I would like to make a dent in this before we have to have criteria, because my fear really is that every time someone wants to order it, Elijah's going to have to screen it. All right. So we will set some up then. So these are the panels that are currently available through Mayo. ARUP has very similar ones. And so ignore the paraneoplastic, and then now this is their guidance. So if you look at the encephalopathy panel, that's going to be our kind of prototypic. Someone comes in and we're concerned about a rapid alteration of consciousness with, seizures or CSF changes. Rich, the dementia panel is probably the one you would want in your clinic when you have a high suspicion. There's a lot of overlap between those two, but there's a couple of differences, right? So the dementia panel is not going to include some of the epilepsy antibodies, but it will include something like Iglon-5, where the epilepsy panel does not, because they tend not to seize, right? So it's going to be a little more targeted, a little more sensitive for the things that you would be looking for. And so this is a variety of the panels. You can find this on the Mayo site. I just thought it was worth kind of showing to everyone. I think for those of you rotating in the ICU and you have these patients who come in and they're in status, they're not responding to, 2 or 3 agents, and you really do start to think about these panels, I would probably send the epilepsy panel in those folks as opposed to the encephalopathy panel, right? You're going to include a few more antibodies that have acute epilepsy, like GABA A, for example, that isn't in the other panels, and is going to be more amenable to acute immunotherapy. The encephalopathy panel, while it covers probably 90% of them, there are a couple of different, it leaves a couple of the epilepsy ones out, and it includes more of a couple that would be more dementia-like. So I think for anyone listening in the ICU, I would probably shift more to an epilepsy panel. It also includes now, as opposed to just the encephalitis antibodies, they've moved a lot of the paraneoplastic, the cancer-associated antibodies into these. So the paraneoplastic antibodies that are associated with epilepsy, as well as the encephalitis antibodies, are now included in the epilepsy panel, where before you had to really kind of look at them and figure out what you were concerned about. The pediatric versus the kind of just general encephalopathy, again, there's some shifts. The age of onset of these conditions really does determine the prevalence and incidence of some of the antibodies. So there's just some shifting that takes place within those. This is from ARUP. So Stacy Clardy out there has been involved in antibody development. They overlap a lot with Mayo and UPenn. They actually interact and collaborate a lot. So all of these antibodies just about are available at the 2 labs, Mayo and ARUP. These are their versions of the panels and all the antibodies that are included on them. This is very easy to find on the website. And you can see certain ones are included in almost every panel, all right, and appropriately so. But when you start thinking about, say, epilepsy versus dementia, you'll notice that there's a few, a few rows that are switched and flipped. So my recommendations at this point, and I think we can develop these into some more firm criteria with the help of the ICU and some other folks here at Duke, is first and foremost, really think about the clinical situation. We should not be sending these in every patient who comes into the ICU and every patient who comes into the ER or every patient who gets admitted to general. I think our yield is incredibly low. If you look at all the numbers at Duke, we're hitting about 1%. All right, that's not very good for a $1,400 test and a $900 test in the CSF when we're sending 1,000 of them a year. Right? The ICU has gotten pushback because their positivity yield rate is about 15%. Quite frankly, I think that's pretty good compared to everybody else. But I think we can improve on it. And before you send this, patients should really have an MRI. And if someone's admitted and you're thinking about encephalitis, I mean, they should really get a lumbar puncture if this is on your differential, right? Now, should you send it immediately if you're doing the LP early in the morning or you happen to get time to do it? You can save the CSF. It can sit for 28 days and still be good and testable. All right. So the lab can hold it. You can wait to see if the protein and cells come back abnormal before you blanket send it off. There's no reason it has to be sent right away. And it can just be refrigerated. It doesn't have to be frozen or on ice, anything like that. I would say, again, to reiterate, I don't think there's any good reason to order these things in the middle of the night when people come in, with the exception perhaps of you're highly suspicious and they're going to get a dose of IVIG in the next hour, right? And that doesn't happen very often. But the reality is if someone comes in overnight, there's really no good reason to draw these antibody panels without a discussion on rounds. There's just no good reason. It takes 2 weeks to come back anyway. It's not going to change your management. You're going to do whatever you're going to do. So it can wait an hour, to be sent off. And I do think people should start to utilize this APE2 calculator. It's incredibly specific and sensitive for people who are going to test positive for an antibody, right? That's what it was geared toward, finding antibody positivity. Use targeted panels whenever you can. And I think the epilepsy one is a really good one that should be used in a lot of inpatient and ICU settings. I suspect that we will still use a lot of the encephalopathy panel in our clinics because of the different setting and the different way people present. And then in Rich, when you're sending these, I would go with a dementia panel. And again, from the lab, we did discuss this with the lab, both here and from the Mayo information. These things can sit for 28 days. You do have to take the mail time, transport time to Rochester into account. But it takes a few hours to get a protein and CSF back. If we can get the lab to hang on to 3 or 4 cc's and not send it off for cytology or flow or all the other things you're checking, I think it's very reasonable to have this sit and stored and then added on after the fact, right? And then if CSF comes back negative, then you're not going to have to worry about it because most of these patients are going to have CSF abnormalities, the exception being MOG and LGI1 in general. So for the sake of time, what I'll do is I'll stop there and open it for questions. Treatment-wise, I just think I'll say it's okay to treat possible or high suspicion for AE. Just make sure that if you're giving IVIG, these do get sent off first. You also probably shouldn't be starting IVIG in the middle of the night for AE in general. So we'll stop there. Questions? Yep. Will do. Yeah, Joel.
Chris, is there a way to order for them to refrigerate outside of the CSF?
So I believe there is a way to say, store for additional testing. I've done this before, and now it's been a while because I used to do it some with the LP clinic. I would set aside an extra tube and just say, please save for add-on. What the process on the inpatient side is, I won't know. But if there's extra CSF in general, they save it for about a month. You just have to make sure that you're
Depends on how they process it.
right. And then if you order a lot of flow or path, you know, they'll send pretty much every drop over. So that's a discussion I think we actually need to have with the lab is how can we ensure that if you, Yeah. for these panel, the CSF panels is 3 cc's is kind of the minimum. They want 4, but you can get away with a little bit less. So 1 second here. Shri.
Hi, good morning. Thank you so much. I didn't have any question, but just wanted to comment. This was a really excellent talk and very helpful for our ICU group and also all the trainees in the attendance. So thank you so much for putting this presentation together.
No problem. So let's see here. So Natalia had a question. Is it reasonable to almost never send serum panels if the patient is eventually getting an LP? So I think I would be, some of it depends on suspicion. I think in most cases, most experts are still sending both. I do think that if you were to say, get an abnormal antibody in the serum that you don't see in the CSF or CSF is not inflammatory, then you really have to question its significance. And if you're doing this on the inpatient side, I would say if the CSF is otherwise normal, yeah, I think you can get away with just CSF if that's the only one you want to send. I do think there is a place for serum, however. And so I still, if I have a high suspicion, I send both. I just don't send this very often. You know, so I actually queried Slicer Dicer by provider to see, you know, which of us sends all these antibodies. And you might think that me kind of being over in some ways, the autoimmune encephalitis clinic is high up there. I'm about number 12 on the list, right? In the last year, I've only sent about 15.
But that's the same in dementia clinic. We're the ones who never order the cognitive test.
Right. So I just think we should be a little more judicious in who we're sending it. If it doesn't fit the clinical scenario, I wouldn't send it at all. I think if you have a high suspicion, I'd tend to send both.
But you will help us with the criteria. I mean,
Yeah.
Because it's just shot random ordering. We're so.
I'm aware.
We're so washed in CSF. Like my standard order panel, you know, which has Alzheimer's protein, also has an autoimmune encephalitis.
Delete that one.
That's why I sent you that big line.
So truly, from the lab here, the CSF autoimmune panel costs $900 per test, and the serum is $1,400. And we are sending more and more of these every year. I mean, you saw the numbers we're talking about. You're getting into the 1,000+ range. You know, 1,000 tests at $1,000 a pop.
Isn't that on the outpatient side? That's cash money, right? I mean, on the inpatient
Depends who you're
side,
sending it on. The inpatient side is where a lot of them are being sent.
So if everyone doesn't know, on inpatient studies, you don't get any money for ordering tests.
Yeah.
On the outpatient side, the insurance still comes.
The majority of these are coming from inpatient.
So inpatient, the hospital loses money every time you order it.
Yeah. Annie.
I just wanted, excuse me, I just wanted to comment because you had asked earlier if the 2 panels are near each other in the order set, and in the lumbar puncture order set, they are right below each other. The perineoplastic and autoimmune.
I kind of assumed that was the case. I think that's something we need to get corrected.
Those of us who don't understand.
Oh, so when they're ordering these panels, you pull up an order set for, say, lumbar puncture, and it lists a bunch of labs. It's got both of them right next to each other. And so an encephalitis panel, a perineoplastic panel, and then 10 other tests that you may not want. And depending on who's ordering and how quickly you're going through, you get click happy, and there you go. And so I think we end up with a lot of tests because while order sets make sure we don't forget things, they also make us include things that aren't useful.
What's that order set called?
I'm not sure you need to know that one. So Carolyn, can I comment on bands, IgG index, neopterin, kappa, and CSF? And so that's probably beyond the scope of where we're at this point. I will say there's a lot of mixed data on bands, IgG index, what percentage of patients test positive. I will admit I tend to look very much more at cells and protein. Our internal data on bands is very hit or miss. And then there's a lot of other markers that we did not get into, and I specifically stayed away from pediatric encephalitis. So Carolyn, I'm going to defer that to another talk. All right. And then I think for time, we should probably
It's okay.
call it.
Anyone who needs to go, can go. This is our chance to get all this off our chest.
All right. Other questions? All right. Thanks, everybody.
Yeah, thank you.